Online this morning?
Not yet.
Not yet. Well, good morning, everyone, and welcome to the November edition of Grand Rounds here at VRI. It's my distinct pleasure this morning to introduce our speakers, Dr. Kevin Potty, Esther Shoemaker, Irene Madomka, and Christine Lalonde. Dr. Potty is an associate professor of family medicine and epidemiology community medicine at VRI in the University of Ottawa. He's lead of the migrant subgroup of the Campbell and Cochrane Collaboration Equity Methods Group and practices as a family physician and is a family physician at the Briere Family Medicine Center. Esther Shoemaker is a medical sociologist who studies models of care to advance shared decision making and seeks to improve maternity care services for vulnerable populations. She collaborates as a postdoctoral fellow with Dr. Claire Kendall and has recently completed a PhD in population health and a diploma in health services and policy research. Irene Madomka is a RA working with Kevin Potty, and her interests include marginalized populations and how they access care and health resources and global health and education. And Christine is a citizen scientist and peer support worker at the Shepherds of Good Hope in Ottawa, and she collaborates as a community scholar with lived homelessness experience and research teams with Claire Kendall. So, welcome.
I'm just going to say a couple words. I think it's really important to recognize the Inner City Health Associates of Toronto, which are physicians that put aside money for inner city health or homeless health projects over the last, I believe, 20 years. And then they've decided that they've identified two big projects that they were going to fund. So they decided to do a call for proposals for evidence-based guidelines for persons that are homeless or vulnerably housed. And so I think this is the project that we're going to be talking to you about today. We're about six, I don't know if it's six, I should count exactly, but 6 months in or 7 months in, or is it? May. Yeah. So we've kind of launched, and it's exciting because we actually have some real material for you guys today. I think we're really rolling. The project is moving along very nicely. I just wanted to say one of the things that happened in our meetings in Montreal, like last week, we had a couple-day meeting. We had a kind of one meeting with almost 50 people, different disciplines. I think we had at least 3 community scholars. We had several different perspectives, and so we had a really interesting meeting at St. Mary's in Montreal last week. But one of the things that came up was, who are we making these guidelines for? And I think this is going to be an ongoing discussion, and I just want to bring, it's important for the listeners as you listen to what we're doing, as to what this is for. It's a little bit of tension between, is it for family doctors or the psychiatrists or the social workers in the field? So we recognize that we have different disciplines. But since kind of Claire and I are leading this, and David Punk is involved, I think the family medicine has like a central role in this project. I think people would agree with that. But we know that we're not the only ones doing the work and the only ones that can do the work. But I just want to say, Tim Aubrey is also here with the Housing First. You'll hear about that as well. So I just want to put this out there, and I hope we can maybe have a little discussion in our team as well about what is the scenario we're trying to address. So this is a kind of a real scenario. I have a 36-year-old patient of mine who arrived in Canada as a refugee from Guatemala. And I've been treating him with post-traumatic stress from his refugee days. He was also an indigenous person from Guatemala as well. And he was within the system and housed and actually coming to appointments with me. And then all of a sudden he kind of disappeared. And I don't know if I have experienced this before, so that people disappear and you cannot, even though I knew he disappeared and I was worried, I couldn't reach him. So then maybe a year or two later, he comes back and he tells me that he's kind of become disconnected from his original friends and world and moved into another world and found the Inuit community on the street as his new people, and he feels very connected with this group. And at the time, but he says he's quite worried about things that happen on the street, and so he asked for an HIV test and hepatitis C test and a whole series of things, and but then he disappeared again, and he didn't actually go for the test. And then I kept getting these reports almost every 2 weeks, usually from the Emerge at the Montfort, where he was getting a CT scan of the head, and he was repeatedly being beaten up on the street, almost weekly. It was like really hard to read these reports coming in. And then he finally came back, and he acknowledged how difficult life was, and he actually did the test, and he had HIV and Hep C, but then he disappeared again, and then it's just me. That's the way I see this guy. Me receiving reports from Emerge, and they're always CT scans of the head. It's really disturbing. So I mean, the head injuries, and I've actually stopped receiving them, so I'm very concerned. But I guess as a family doctor, I guess I am sitting a bit in my office. I'm not running around after him around in Ottawa. But I was wondering, what could I have done differently, or how do you manage people that seem to be falling outside of your normal kind of care? So I just kind of propose that our guidelines are not really for the specialist inner city or homeless health doctors or whatever that may already know of programs and they have someone they could call, which I wish I had, but more for the docs, and that's quite a few of us, that may see people and we have opportunities to intervene, but we don't know how or when to intervene. So you can think about that as we go through our presentations.
Thank you, Kevin, for giving us this context, because it shows how important the creation of these guidelines are. And for this presentation today, we're showing you how we are selecting the priority conditions for homeless and vulnerable housing people to actually create the guidelines. I just want to acknowledge the team. It's a large team process. Our team is from across the country. I'm not going to read the list of people on here, just to show you there's many of us, and we have no competing interests. So Christina's going to come and give us some introduction.
So our definition as a team of homelessness is defined as an individual or family without stable, permanent, appropriate housing, or the immediate prospect, means, or ability to acquire it. And that's actually that's the Canadian Observatory on Homelessness, 2012. So the definition includes vulnerably housed people, so people living in shelters, rooming houses, hotels, couch surfing. In 2014, out of the estimated 235,000 Canadians experiencing homeless that year, 27.3% were women and 18.7% were youth, with a growing number of seniors. So the high burden of illness among homeless. So homeless and vulnerably housed people experience significant health disparities compared to the rest of the population. Homeless people often have complex health needs while experiencing barriers to access and uptake health and social services. And practitioners need training and guidelines to negotiate these complexities of caring for the homeless type people.
Thank you. So we knew that these guidelines are necessary, and the Inner City Health Associates of Toronto were kind enough to fund our project to create those guidelines. So considering we don't have the funds to systematically collect evidence on every important topic that is out there, we needed to find out first what are the most important health conditions that both practitioners and people with lived experience believe we need to tackle. So we asked the questions. First, what do practitioners consider to be the health priorities that need to be improved for the health of homeless and vulnerable people in Canada? And the second question, what do people with lived homelessness experience believe are the priority conditions that we need to work on? So what we did is we created a modified consensus process in order to find out what all these experts, and here I'm talking about experts with experience and experts working in the field, believe are the conditions we need to look at. So in summer this year, we set out to create a survey. We looked at the literature that is already out there. There's a lot of homeless health guidelines internationally, but they're all not evidence-based. But we looked at what are the conditions that they are focusing on to choose a number of priority conditions that we thought might be important. We showed those to a handful of practitioners, and we sat together with also a handful of people with lived experience to see if the conditions we named were understandable to everybody who we were going to give the Delphi survey to, and if they made sense and if there's others we need to add or change. So based on this, we created the phase 1 survey of the Delphi, which was sent out in May this year, and it was sent out online as well as in paper, and we had people from all across the country fill out the survey. After phase 1, we get the results back, we analyze them, and in the second round, we provide people with the responses of the first round, so they know how people ranked conditions. So we gave them a number of conditions. We asked them to rank them according to their top priorities, and to add conditions if they think more are needed. So people did the ranking process. In the second round, we give them back the answers of how people ranked conditions, and we let them rank them again, while also having added the new conditions. And right now, the third round is ongoing, where we return again the answers to people. We say, these are the priority topics you decided on. Do you consent? Do you agree? So I'm just going to give you here an overview of the people who have been participating in our survey, and Christine is later going to give you some of our preliminary results. So from practitioners, so I'm calling them practitioners, those are primarily primary healthcare providers, but also health researchers working with homeless people, community health advocates, social workers. We gave this survey to them, and we had 114 who we invited to participate. Those are people who had already ahead of time said that they might be interested to participate in this project, as they were specifically chosen. Out of those, 84 completed the first round of the Delphi, then 68 completed the subsequent round, and the third round is ongoing, so we don't have the exact numbers yet. We hope we get most of them. Then we also found people with lived experience to participate. When in our original approach, we went to people who we already knew people, and we also asked every practitioner who answered the survey if they could please help us find somebody and help assist those people to participate in the survey. Using that method, we only got just barely under 30, which was really good, but we thought that's not good enough because we want some relatively equal number between practitioners and people with lived experience to give us their input on what's important. The guidelines are supposed to speak to the people who are living on the streets. We can't make those decisions for them. So we took an additional approach. We had already started Delphi round 2 among the practitioners, but we chose, so Kevin has a lot of contacts across the country with community health agencies, and we asked them very directly, we're going to send you paper copies of this Delphi, can you please go to your people, ask them to participate, help them to participate. So we didn't have any funding to make this happen, but they thought it was important enough that they did. And altogether, we were able to get results from 76 people with lived experience from across the country. So we have the answers from them for Delphi 1 and 2. We don't know yet how many we're going to have for Delphi 3. It might be a much lower number because it's very difficult to find the same people again. Because that's important in this Delphi, that we don't add people after certain rounds. It's going to be the same. So I'm going to give you an overview of the participants because we are quite proud about who has participated, and it shows how representative it actually is. So when we're looking at the practitioners and at the people with lived experience, we have people from all age categories included in this Delphi. On average, people with lived experience were a little bit older than people with who were working in the field, but not much. It's very, very similar. Also, in terms of gender, we actually expected more people with lived homelessness experience to be men, but we were able to get a lot of responses from women. It's actually relatively equal. From practitioners, we have a slightly higher number of women answering than men, which is interesting too. It shows the field is becoming more feminine. But in general, it's very equal, which is nice. And here's our geographic diversity, which is fantastic. We were not able to get any participants from up north, and most of our participants are from major urban centers. Of course, this does exclude the voices of people living in rural areas, which might be very different needs, but we might not be able to address them in a national guideline at this time anyways. So we were focusing on the low-hanging fruit, on the people who are the most representative, and those are the people living in the major urban centers. So we were able to get people from Vancouver, from Edmonton and Calgary. We had one person from Winnipeg in Ontario. It's not just Toronto. We actually said we capped at 20 people from Toronto so that Toronto wouldn't be overrepresented. We also have Ottawa, we have Waterloo and Hamilton. And we have people from Halifax and from Newfoundland. Yeah, that's it. It's all over the map. Most of our participants spoke English, but a few of the participants, which were all the ones from Quebec, also answered the Delphi in French. And we had a few other primary languages that were named, but the Delphi was only given out in English or French. Now, in terms of length of homelessness experience, so most of the people who answered said they had been homeless, had been homeless for less than 2 years. But we have people in this group who have been homeless for more than 11 years. So again, we are happy that we have quite a range of responses. It was clear that it wasn't just one group of people who all knew each other who were answering, but it was really spread out, which gives us a bit more confidence in our results. Now, when we looked at the professional background, so this was primarily for the people now who were surveyed as practitioners, most of the people who answered were primary care physicians, who we initially thought this is where we are primarily writing the guideline for. So we really wanted to hear their voice. What do you think is something that you would need in your office? What would help you to help people with homelessness? We also have a few specialty physicians, nurses, public health experts, and social workers. And we have a number of researchers in the field as well. So Christine is going to show us the results of this Delphi.
So when it comes to prioritizing social determinants of health, so if you notice in box 1, this would be the persons with the lived experience, and this on the box 2 is practitioners and others. So they both agreed that housing was number 1. They both agreed mental health and addiction was number 2. Number 3, care coordination over there. And then number 4, changes. So persons with lived experience facilitating access to adequate income was their number 4, and chronic disease management for the practitioners and others. Number 5 changed as well. So the chronic disease management and end of life care. Number 6, Hep C, HIV, TB, all the others, and that came in 7th for the practitioners. So that just shows the differences in the boxes. So it's very close.
So this is great, but so I see you've got the same 8 in the 2. Did you start with more topics that you eliminated because they hadn't ranked high?
Yes, we did.
And did you end up just by, the same 8 in the 2 because those were the top 8 priorities for both?
We're only presenting the top 8. There's more below, but they fall off. So we are actually, our guidelines, since we don't actually even have the resources to create 8 guidelines, we're going to create 4. So this was to really just see what are the top priorities, and what really stood out for us is that the top priorities.
But I think Simone might be asking, which is what happened, was there was some movement. So
yes.
This is not necessarily a done deal from the first thing.
No.
We had some different results early in the survey, and we showed. And I don't really want to talk about that, but I just think that's really important in Delphi is that it's a consensus building thing. So this looks really almost like too good to be true. So it wasn't necessarily like this at the beginning, but it wasn't that far off.
Yeah, it actually stayed quite consistent. We were positively surprised right after the first round that the social determinants of health really came through for both groups. So even like the primary care physicians, they said they need guidelines on facilitating access to housing and not on chronic disease management as much. Yeah.
Sorry, you might have spoken to this already, but did you feedback the results from one group to the other group between rounds?
Yes, both
Is it-
groups got the results from both groups.
Okay.
Yes.
But they never worked together, they were two
No.
separate Delphi.
It was, they had actually, no, everybody had the same Delphi. Everybody had the same Delphi. We made sure that the Delphi everybody got was at the level of language that everybody could understand it. So we did not create different focus. I know in some systems, people create a focus group with people with lived experience. We intentionally did not do that.
Okay, so
Because
that
when we actually
explains-
sat together with our homeless health, with our experts who have experience at the beginning, creating the survey, we brought that forward. We said, a lot of studies do this. They do the Delphi as a survey with the practitioners, and then they do a focus group afterwards with people with lived experience. And they hated that idea. They said, no, we want to be treated like everyone else. You want our opinion? You need to treat us like everyone else. So we made sure that everybody got the same survey at a level that they all could understand.
Maybe I can ask Christine a question. So I think one of the things that we met when we started surveying people in the organizations and communities was that everyone feels that someone is surveying them. This was like so they felt that it was a survey and that someone's going to take their data and not necessarily do anything with it. I know this is a common scenario that you will actually study a population but not necessarily work with the population. But you know, Christine, you've had an experience in this over the years, or
That's usually how, what you just described, that's usually how it ends up. They're just researching it. It's not going to be guidelines for something or going to actually make an impact when it comes down again. So. But as soon as I looked at this, and I was one of the lived experience in the Delphi in the beginning, and I was shocked that we were very, very similar. So the mindsets are basically the same.
And we also, I just introduced this, we also asked people to rank priority populations. So this was a very tough one. We actually asked in the Delphi, we have a number of populations that we know we need to focus on specifically within each of the guidelines, because they might need we might need to do some additional research on how we can facilitate care for those populations. And we actually asked people to rank them, which is, it's very hard to ask somebody to do that because all the populations are important and we need to touch on all of them. But by asking people to rank them, we made them think about it. Which do you really think needs the most help at this point in time? And here are the results from that exercise.
So we're going to try and focus on the first 5. And you can see it's very close again, but with the lived experience, the youth, no, wait a minute, with practitioners, sorry, vice versa, the youth scored higher. So it's very, very similar once again.
And in the end, it doesn't matter if it scores as a 1 or as a 5. We said we do our cut over 5, so those 5 will be selected. It's not important if it's a 1 or 5. That's less relevant. Do you have any questions about this? So now, based on these results, we have started to form working groups. Our Delphi is not completely finished yet, but we don't have enough time to always wait for everything to finish, because we need to start selecting participants of these working groups. Most of those are self-selected. And the participants of the working groups are the people who have answered the Delphi, who participated in the Delphi. Most of them at least. And those working groups are now meeting to select the evidence. That's the wrong word. Not to select the evidence. So we have a technical working group in Ottawa, and we have working groups across the country on each of the topics that we have presented to you. And together they will collect the evidence for each of the topics to create the guidelines. And I need to acknowledge again all the different community agencies from across the country. We would have not been able to get over 70 people with lived experience without their help. They were roaming the streets for us, and that was fantastic. Do you have any questions about this part? Because Irene is gonna now present something about the process of actually creating a guideline. Yes?
As I was looking through your results, I know you were focused on their priorities to address through guidelines, but some of the applicability of the evidence depends a little bit on the population, and you have a unique engagement, to look at the strengths of the population you're working with. What resources might they have where evidence-based approaches, like, do most people have access to a mobile phone? Do most people have a single location they would go to as a trusted? I'm just looking for resources that might be more common across this population, where some of the evidence could be brought into play. I mean, people like me don't necessarily have a good understanding of what the strengths of the population might be. And I see that wasn't in the Delphi, but wondering if there's any way to collect that kind of information to better apply your evidence.
Well, I don't know if it was clear, but Christine is leading a community of scholars group. So we, for
That's what I was saying,
practicality,
you've got,
we kind of used, and so Christine actually probably recruited, I don't know, 20 at least of those people herself. So we, our community scholars are kind of one of our key links. So I think but I think it was a very, let's just say that the situations were varied, and one of the like, I know that 12 surveys came from Indigenous Health Center in Vancouver, which is a very challenging one, but our people got in there, and I think that it was great to have it in different corporations. But I'd say that now I don't believe we have easy ways. We have our community scholars, and then we might, and as we go through, be able to feedback via the organizations. So I feel like what we do have is our community scholars and the organizations. I'm not so sure we actually have those people on with cell phones, I don't think.
But you mean if you're a practitioner, that you would know about the strengths of the homeless person coming to see you? Like if you would,
if there's a way to assess what they might be.
that's
right?
a really
This is-
fantastic question. I think it might be very relevant to include that in the guideline. We haven't asked about it in the DASPA at all, but we should keep it in mind that we are not just looking at the barriers, but also what do they already have that might facilitate them taking the next step.
I know the other community scholar actually set up some of the participants with email addresses so they could participate and collaborate and stuff, so that was great.
Thank you.
Thanks, guys. That's good.
So, good morning, everyone. My name is Aureen, and I'm hoping to take you through the process of how we went from the Delphi results and how we're hoping to incorporate that into a systematic review or guideline document. So, as Esther mentioned, we had some priority topics that came up from the Delphi, and we've kind of grouped them as such. So, mental health, addictions, care coordination, income, housing, women and youth, and then we're also going to have a qualitative synthesis to go over the values and preferences of the key 4 populations that were identified, and we're also going to focus on implementation and policy towards the end. So we created working groups to go with each of the topics, and these working groups were made up of a group lead. So this was an expert that had experience in one of these topics for many years, and it was really helpful to have a lead to kind of guide where we went. There's a technical lead, such as myself, a research assistant, who worked on collecting data. We have lived experience members to give their advice and opinion, and expert members as well, who are other healthcare practitioners and workers. So the expert in each of the working groups informed the creation of a list of known interventions for each of the topics and guided the scoping exercise, which I'll go over in a little bit. The interventions to be included aren't final at this point. We're still discussing them with our working groups and coming to a consensus on what interventions we ultimately want to include in the systematic review. So I'm going to go through the example of what we have done so far with the mental health and addictions topic. So the Delphi results showed that 82% of lived experience participants voted mental health as top priority. And we know that Canadian studies have shown that homeless populations are at a higher risk for experiencing substance use and mental health conditions in comparison to the general population. So we do know it's very relevant in this homeless group. So I've created a PICO. Our population are homeless people, either chronically visible or hidden, vulnerably housed, and other related marginalized populations with severe mental health conditions. we have some interventions that we think might be promising, and I'll go through that as well. The control will vary based on the studies that we find, and some predicted outcomes are shown here, and I'll go into that as well in a little bit. This is a quick logic model to kind of conceptualize what we're hoping to find. So we have our population, and in that population, we will detect or identify homeless individuals with or at risk of developing severe mental health problems and or addictions. The interventions would be introduced, and we'd also look to see if there are any possible harms associated with the interventions. And perhaps it might be better to show this in a linear fashion and put all the outcomes together, but this is kind of a rough draft of my logic model. The critical or the main outcome would be decreased morbidity and improved or decreased mortality, and we're hoping as well to find some other outcomes as well, like improved housing, reduced substance use, decreased employment barriers, and less money spent on substance use, as well as improved quality of life. And again, these outcomes might change based on the actual systematic review and what we find in the literature. So I just want to walk you through my scoping exercise. So the purpose of doing a scoping exercise is to ensure that we have literature and evidence out there on the intervention that we're looking at, and so that we're not going into a systematic review blindly and hoping to find things. It's just kind of a method that we use to kind of predict what we might find in our systematic review. So the interventions that I looked at for mental health were guided by my expert lead, Dr. Vicky Sturgiopoulos, who's a psychiatrist in Toronto, and she has over 10 years of experience in this field, so she was able to guide me and provide me with a list of 8 interventions. Oh, sorry about the formatting, but 8 interventions that are commonly used for people with mental health. So what I did is I took these interventions, I did a quick search on Google Scholar for the evidence out there, and I created summaries, and I reviewed this with my working group. And from that, we were able to kind of sort the interventions into different topics. And due to the feasibility of the project, we couldn't have all 8 interventions under the mental health topic. So, for example, supportive housing is an intervention that's provided. This overlaps with the housing first topic of our project, so we thought we could move that intervention into that group. So I'm just going to walk you through the assertive community treatment intervention. Hopefully it'll give us a better idea of how we've guided our decision of looking at this intervention. So assertive community treatment is, the definition is a team that provides services directly tailored to homeless persons' individual needs and helps them achieve their personal goals. It consists of a multidisciplinary team that will go to the natural environment of a homeless person, whether that's their work, their home, or their social setting, to work with them and try to help them achieve the goals that they've decided. And there's about 10 patients per case manager, and the availability is 24 hours, 7 days a week. So when I looked at the literature, I was able to find quite a lot. And just to summarize, there's a very nice systematic review that was published in 2013 that shows the effectiveness of assertive community treatment in homeless people with severe mental illness. And some of the outcomes were increased participant interaction with professionals. It was effective in shortening the length of psychiatric hospital stay. It improved housing stability for dual diagnosis. There were fewer mental symptoms, higher satisfaction with life. The costs for inpatient services were not more expensive when compared to standard care, and it did not affect substance use. And again, I found some more literature supporting that. So this kind of guided the outcomes that we are hoping to find when we perform the actual systematic review. So I performed those scoping exercises for the other interventions that I mentioned as well. That was just an example. Yes.
I think this might be a good spot if people have questions before you go into the next part.
Sure.
I just want to let you know, we've got about 20 minutes for the finishing and the discussion. So just to give you an idea, depending on what's left.
Before the next session.
Well, before we end this session for a break,
Oh, then we have break, then we have the next session.
then we have the next session, yeah.
Yeah.
So just to give you an idea.
Because I just want to, like, this is something a lot of people don't necessarily realize, that when you do a systematic review, there's always this scoping exercise. It's not always talked about in public, so it's actually done, because, like, if you do a Cochrane review and you submit to get your protocol, your title, and then your protocol accepted, you have to do almost a lot of reviewing before you can actually argue that that question and that PICO makes sense. So I think that's when we use this term scoping exercise, this is what we call it, the Canadian Task Force. So we would never do a systematic review, which is like a couple $100,000, which we give like McMaster Evidence Center to do, until we've kind of actually already kind of scoped it out and tried to make sure it's almost like in a Cochrane-like readiness. That doesn't mean that the stuff that's you find in the way is totally removed, but it does start to fall away from the core review process. So this is something we noticed during, I think, at the meeting in Montreal. People find that it's very disturbing to watch some of their favorite interventions may not make it through the, like this is when you do a systematic review, you have to focus down and really go for the top evidence on the top interventions. But that could have implications for other things.
I guess the obvious question as I was thinking about this in Montreal is, what is the risk of missing something in the excluded interventions based on a quicker scope that you don't then systematically review? Do you see what I mean? So what is this based on? It must be a validated method. You've done this before, but can we quantify that risk that we're missing something in the excluded interventions based on the scope?
I have to say, we were kind of like, it was almost like surreal that on the Sunday of our meeting, the Lancet published a massive kind of scoping review on interventions that are effective for excluded populations. It's almost like too good to be true. This was not a grade or Cochrane review or a grade-based guideline review. So it basically gave us this pot of, they did quite, I think, a reasonable review, a little bit larger population focus, but in a way that's one of the ways. So basically I agree with David, but I think that was really helpful. You don't usually have that. Often you have to do that yourself. So we have that plus our own, we don't want to miss anything, but to be honest, when we're dealing with RCTs, I don't know if anyone else wants to comment, the RCT world is a lot easier. When you go down to the observational studies, and let's say the controlled observational studies, which could actually make a recommendation, that's where it becomes the gray area. It's so much harder for us to move into those areas. If we can do RCT scoping, it's really organized at the RCT level. A lot of the databases, you can actually handle that. But if you want to go deep into and start talking about grade literature, you're really in trouble. So your resources become really large as you go into these other things that are not as well indexed and easy to find. But so I guess there is that small risk, but often those reviews aren't as high quality, so they often don't necessarily drive things as much.
It's also the scope of your review. You're looking for the existing evidence, where the evidence base exists, and that you acknowledge the limits of that, which is there's tremendous innovation happening. We may not have the evidence to support a number of things, and that's either a call to action where things could be positive, but it's recognizing the limits. We look at systematic reviews like the Holy Grail, but they show existing evidence only.
And I guess it ties into the gap mapping that we talked about last time. So if we notice a big gap in the evidence, maybe we should note that. Maybe we should write about that.
So that actually is a good point, but this is definitely will come up. If we don't get to pick the recommendation, we only get to pick the area where we get to hone down the evidence. And ultimately, the evidence may say big gaps, major concerns, can't go farther, or don't put this in large scale everywhere yet because this doesn't look like the evidence is ready. So absolutely. I mean, in the refugee guidelines, we had at least 3 like that. We were definitely the PTSD, the domestic violence, the child maltreatment. They're all like, don't implement these things yet. We're concerned that there could be harms. So what often happens is that you have this concern that there's potential harms and the benefits aren't super high, and you start to question, But it's hard to know until you get to the end of your process, which is a little bit hard. We can only kind of guess, but at the very end, we have the numbers to weigh.
Just a thought, maybe just go back on something, thank you, Irene. I don't know, the one that shows the interventions, sorry. Yeah. I guess, there's 4 areas, right? And we'll talk about housing after.
Maybe the other slide you want.
No, this one, well, it's just that the question I had was, like is it okay if there's overlap in the systematic reviews across the areas? Like some of the same studies are going to appear like I'm thinking that they will in terms of housing and this mental health and addictions focus.
So at Cochrane, I guess I'm not a Cochrane editor, but I've seen this, that the Cochrane editors have to handle this. So that's why they register review. So in a way, we're going to be registering our reviews once we decide this is what we're going to do. We're going to register with Campbell in this time, a Campbell review. But that's why they register. And then they're going to look for the PICOs. And then the editors of the journal will look for overlap. And they'll actually say, is this the direction of grouping that, say, Cochrane is going? And I get in trouble with this with my Cochrane review on HIV testing. And there was a WHO meeting, and they decided they weren't going to talk about rapid testing anymore. They're going to talk about community testing that included rapid testing. So I got kind of like shadowed a little bit there because they shifted based on an international meeting toward another configuration. This can happen it's not, anyway, it was like, anyway, it's Cochrane trying to keep their data organized as well, right? So they decided, that it should be about community testing because WHO decided that, and community testing includes the rapid testing.
Let me ask Irene, how much more time do you?
2 slides, maybe.
2 slides, okay,
minutes.
so we're good. Why don't we finish and then we can have a broad discussion.
So just want to talk about the next steps. What are we doing now? We're still coming to a consensus on the interventions that we want to include in the systematic review. And once we've defined our PICO questions, we'll move forward and look at inclusion and exclusion criteria for the papers, take this to a medical librarian, do the literature search, perform data extraction, and once we've synthesized the findings, hopefully we can give a recommendation on the intervention, or if the evidence isn't strong enough to give a recommendation, maybe we can talk about implementation or just mention whatever we found, if that's a lack of evidence or a harm or some benefits. I think that's all. Thank you.
Thank you. So I have a question, which is, for those of you in the field, this can be a very, very sort of maybe basic question. But one of the priorities that was identified is around housing. From the little that I have learned about homelessness, because maybe define to me, what do you mean by housing? Do you mean sort of appropriate shelter, or do they mean independent housing, where I actually, live in an apartment, rent, and I guess it depends. How was the question asked around housing? Because this may be a misconception, but I understood that many people who were homeless didn't want to have the attachment of the housing, the responsibility, but maybe that's wrong, and maybe that's what this is showing. So just to clarify, what do we mean by housing?
Yeah, I mean, ultimately it's permanent, stable housing.
That's what it's meant.
Yeah.
Okay.
Yeah. I mean, there's different types of housing that qualifies as that. I mean, there's independent living, regular housing, specialized housing. There's also, there's research on transitional housing.
Yeah.
But we really mean that if people ultimately end up stably housed for an open-ended, hopefully a long time period. There's actually that idea that people don't, they don't want the responsibility, there's very, very few people like that. I mean, most people, and they've done a lot of surveys around what's their preference for housing. In fact, preference with 80% plus of people who are homeless is just regular housing, not specialized housing. Yeah, I mean, there's some people who might want some specialized housing that's more congregate or group related, but it's very, very unusual that somebody. I think it's maybe a kind of stereotype that exists in the culture.
Yeah.
You know, it's kind of the happy vagabond. You know, but it's not. It's
not
certainly
real.
not what we see now.
No, it's good you clarified because I don't know that area.
I just wanted to comment on this because this happened, in our meeting in Montreal, and I think if you're really experienced, maybe inner city health person, you think, well, I don't want a recommendation on housing. This is so obvious. Practitioners do not need that recommendation. But I have to confess that I'm like Simone, that although I know there were some programs out there, I had no real clue of how effective those programs could be, and maybe not even as much understanding of how important those programs are. So I'd say as a family doctor, I would like my other colleagues that we should hold on to that recommendation line, because although the people that are experienced might know, most of us don't appreciate the subtleties. Yeah. And when we do the recommendation, we get to show all the evidence. When you don't do your line, you actually drop it. So let's say we dropped housing, I would say, oh my God, we're going to lose a really important part of our project. We can't say much in our review. But this is how the evidence-based things work. Sometimes you have to hold on to things just because, I feel the same as Simone, that now I understand a lot more, but I have to say, sometimes you're just working away, you just don't know this other world. So, sorry.
I'll just add on that. Just mention that I recently joined the board at the Centertown Community Health Center, and a really important issue that we've been discussing is rooming housing. And there are rooming housing in the Centertown area and downtown Ottawa that plays a huge role in shelter occupations. I mean, they're talking about building a massive shelter in Vanier. There's a lot of controversy surrounding that, and it's about putting essentially a large number of people in one location. And there's a lot of backlash surrounding that because it's important to have more rooming houses for people, allowing them to be, integrated in the community and in separate areas, but also the safety of rooming houses. That is something that CCHCs, or the CCHC and other CHCs have been pushing for, is implementing legislature which would force someone to come in and investigate and ensure that the rooming houses are safe, because there's a lot of issues with the safety and conditions of rooming housing. And I think that that's a huge area for homelessness, is improving rooming houses in urban cities especially. I don't know if rooming housing was a specific topic.
I think we're going to get to housing in a second.
Okay.
And I don't know if we're going to probably talk about rooming housing, but I think that's the kind of thing that will fall under, I guess I feel that an evidence-based process sometimes looks really narrow, but actually, I think people that have been involved in this, you actually have to handle lots of other types of evidence. So maybe not everything makes it to the grade table, but along the way, you are synthesizing other pieces, conceptualizing other pieces. So I'd say that, I believe that will probably make it part of the discussion and understanding implementation issues.
And even in the early stage with this PICO, but the population, it's people who are absolutely homeless or precariously housed. And I think rooming houses, it's kind of one step out of homelessness, but you're really teetering it. And if it's a lousy rooming house, or it's unsafe, or it's inadequate, people will often end up homeless again.
Exactly. Yeah.
Sorry, if I comment on this. I think in Ontario, especially, which is where I'm most familiar with, part of sort of the room, boarding, lodging house situation is dependent on how municipalities are funding and regulating those locally. And so, in my previous life as a consultant, discovered a whole bunch of different loopholes that can make them better or worse, depending on where the person happens to be living and what type of operation it is. So, from a sense of
think what
And the funding.
yeah, what we're hearing here is when we say housing, people might want to know a little more. What does that mean? Okay, any other questions? Sharon, did you have a question? No? Let me see if we have another minute. We have 2 minutes. Okay, if there isn't, I have a question. So I have a challenge. I'm a reviewer looking at this, and how much does the priorities that you've identified depend on the population that responded? So, for example, I heard you say that you went in a Aboriginal community center or maybe some support unit and engaged a large number of people of Aboriginal descent. So does that influence the fact that that came as a priority? How much so? How generalizable or how representative should these be? Should the participants be? And the other question is, well, what about context? You know, are the priorities in Vancouver similar or different than they would be here, given that there are different, you know, even there's the climate being different?
Well, I definitely wouldn't want a Delphi consensus survey to be viewed like a regular survey.
No.
Where you hope to get 30% of them filled, and that would be like awesome, right? Because you usually only get up 30%. Most people don't get 30%, they get 5% in those surveys. So there's this is a survey world. We weren't doing a survey. What we were doing was really a team building. I wouldn't even want to put this forward as representative or generalizable. I put this forward as the development of a team, and within the team, this is what they came up with. So yeah, I would not want to put it forward as like as a purely scientific method that's generalizable.
I guess maybe you have to be very clear in the population that you've engaged. Because, for example, if you went to
Well, we were like we have to.
well, that's,
we showed,
no,
we
exactly.
showed everything.
That you absolutely.
But that's kind of the way. Just it is. People often push us toward a survey mode, and I really don't believe we were doing a survey.
No.
And then I believe also that we're not doing this was not the definitive choice. This led us down more exploration with the experts, with the community scholars, with their experts. So this is kind of like a process piece. So I think that, so I wouldn't want it to be taken out of context and necessarily said, okay, this is what everyone wants. I would say, well, this is part of a complex series of processes.
Yes. I guess I would look to see whether folks of Aboriginal descent identified Aboriginal communities as a priority, and those with and if that's the case, then I'm not sure that then what this would tell me is that I would want to look at the distribution of vulnerability across Canada and prioritize based on the prevalence.
But you're applying the survey methodology, that survey analysis methods, which is good. So you're applying that to Delphi, which I don't think is right.
Yeah, okay, but Esther, I think might have.
I previously see one,
Yeah.
and among the people with lived experience, which we assumed they would do, but people chose the topics and the populations that were closest to them.
Yeah.
So we saw that.
Yeah.
But we didn't see that among practitioners, and we still had the
Well, and
that's where it's nice.
that's right. I did.
So I agree, this came through,
Yeah.
and we knew that would come through. I asked you living on the street,
Yeah.
you're a 20-year-old woman, who do you think is the population we should work with? 20-year-old woman, most likely.
Yeah. Yeah.
It makes sense.
Yeah.
But
But the fact that you
it's
got
still-
sort of.
It's still got the, if we only would have looked at them, I would be more worried
Yeah.
about it.
And it's not something to
And
sort
of
of
course,
say.
we didn't ask anybody up north, those might be completely different.
Yeah.
Well,
We should
we're-
declare that the indigenous populations have their own project. So there's another grant that each has given to do the indigenous homeless health guidelines. That kind of that came a little bit part of not totally expected process. They wanted to do this research-led project. So that's actually happening on the side, and we're going to work with them a little bit, but they're going to do their own thing.
Thank you. This is really, really interesting, and I'm so glad that you have a number of students and community members involved. It's fantastic. Where is Christine?
She had to go to work.
Oh, she had to go to work. There you go. Okay. Well, thank you very much. So we're going to take a break. We'll be back here. We will start at 9:35 exactly. Right.